Doina told me that you wanted to know a little bit more about leishmaniasis because this was a new or emerging disease here in Romania. My understanding is that you don't have leishmaniasis here. I have been checking the situation with data, and it's in one area there are a few cases, but it's a very rare disease here. Am I correct, or yes? Okay. But despite that, you want to know a little bit more about the disease. Okay, so I will give you some basic information about the condition, and if you want to know more, just let me know. I have selected key points because we don't have too much time. So I will just give you some basic information about the disease, how to diagnose, how to treat. We will see a clinical case also, and then I will mention some strategies to prevent leishmaniasis, and also I will give you my advice about how to, let's say, recommend to your clients when they travel to areas of leishmaniasis, because Romania is not very endemic, but if you go south of Romania, there is a lot of leishmaniasis, and people traveling to other countries like Greece or Turkey, there is a lot of leishmaniasis there, so I will give you my advice about how to prevent leishmaniasis in your clients. Okay? So you know leishmaniasis is caused by a protozoan parasite called Leishmania infantum. Here you see the parasite inside macrophages in the bone marrow. And you know that basically, in most of the cases, the disease is transmitted by sandflies, phlebotominal sandflies, that suck the parasite from one sick dog and then transmit the disease to another dog. There are a few other ways of transmission that has been There are some other ways of transmission that has been documented. So in some cases, there is some vertical transmission or transmission through blood transfusions or through bites and wounds from one dog to the other. But I would say that these transmission ways are not important. So 99.9% of the cases are transmitted by the sandfly. And the disease is only endemic in areas when you have the sandfly. Okay? So this is the situation of leishmaniasis in Europe. So this is a study done in 2009 or 10. And there are endemic or hyperendemic areas in red. So you see that all these are super endemic areas. And you are here, if I'm not wrong. So, and you are clearly surrounded by areas of leishmaniasis. But you are not considered an endemic territory. In the south part of Romania, there are a few cases reported, and probably you know about that. So this has been investigated. So there is a good epidemiological study recently published. I don't know if one of these authors is here in the room, or you know them. You know these people? I know very well Gad Banev, which is from Israel, and he was doing this just to try to clarify this. How is the situation in this area? So how frequent is leishmaniasis in Romania? We know that it's very common in Greece and in Turkey and in all the Adriatic area, in Italy, south of France and Spain, but we don't know in the south. So this paper was investigating the situation in Romania. And as you can see, only 3 dogs were seropositive, and another 4 dogs were borderline, so probably the infection is in the area, and some dogs were positive with PCR, meaning infection without progression of the infection. So the dogs were located always in the south, and also they investigated the presence of the sandfly, so the different species of sandfly, to see if there is risk of extension And they could detect the sandfly in different areas of the south of Romania. So probably there are conditions for an extension of the disease in this southern part. And also you will see for sure cases of dogs that have been in other endemic areas, because you are really surrounded of areas of leishmaniasis. So you will see probably cases coming from endemic areas, and maybe with time more cases from the areas where the disease is probably spreading in Romania. So how is the disease modeled at this time? So when you talk about leishmaniasis in dogs, you have to understand two different situations. One is the infection, and other one is the disease. So we understand that the disease, in most of the cases, start with the inoculation of the parasite by the sandfly. There is a local immune response. In some dogs, probably the infection is controlled, but this is the minority of dogs. Most dogs remain infected with the parasite. And then, if the immune response is good, the dog remains healthy with a controlled subclinical infection. And if the immune response is not good enough, there is a systemic disease. So there is a difference between the two. There's a difference between the two situations. Some dogs with subclinical infection and some dogs with disease. And in some cases, one dog that initially was subclinically infected can develop the disease. For instance, if you give an steroid treatment or develop another condition or disease. So it's possible that one dog that visited Italy 5 years ago now is developing leishmaniasis in your clinic, because was infected at that time, the immune system controlled the infection, but now that it's treated with a steroid for any reason, it's developing leishmaniasis. In humans, the disease has developed 20 or 30 years after visiting an area of leishmaniasis. So it's not uncommon that you see a dog, especially an old dog with leishmaniasis, that visited maybe Italy or another area in the south with leishmaniasis 10 years ago or 5 years ago. Basically, what makes a dog to have the disease, like here, or control the disease is the immune response. Dogs with a very good T helper 1 response usually control the infection. Dogs without this, they develop the clinical signs of the disease. And when the dog is symptomatic, when they have clinical signs of the disease, they have a high parasite load. So these dogs have many organisms in the blood, in the bone marrow, in the lymph nodes, in the skin, and they are infectious to other sandflies and to other dogs. When the dog is infected but not clinically ill, they have a very low parasite load. And then it's difficult to find the parasite because they have just a few organisms. You can skip this one. So, as in the case of atopic dermatitis, leishmaniasis is a very important disease, and there are very good guidelines online. If you need to treat a case or suspect a case of leishmaniasis, go online and use these guidelines for the practical management of leishmaniasis. You will find it in this journal, Parasites and Vectors. And this is a very comprehensive paper reporting how to manage all the cases. How should I do a diagnosis? How should I treat a case? How can I prevent leishmaniasis? So everything, it's there in case that you need this. It's also an open paper, so you don't need to be subscribed or to this journal, so it's open to everyone. So, when you should suspect leishmaniasis in one of your patients? Well, the problem with leishmaniasis is that it's a very pleomorphic disease. It's not like atopic dermatitis that I say, look at this ventral lesion with itch. So, those with leishmaniasis can present with many different clinical signs. I will show you a few or many dogs, but you will see the diversity of presentations. in general, I will say that the most common clinical sign is skin lesions, especially exfoliative dermatitis, scaling, and alopecia, ulcers, and skin nodules. Very frequently, they present peripheral lymphadenopathy. They develop asthenia and anorexia. They show some weight loss and weakness in many cases. These three are the most common clinical signs. Most dogs present a combination of skin lesions, not pruritic, with some lymphadenopathy and some systemic general signs. The dog is more asthenic, it's not eating so much, it's losing weight. This is the common presentation. It's a slow progressing disease. So they will contact you because my dog is not doing well, I've seen some skin lesions, has lymph nodes, and so on. So some of the dogs start to develop renal failure, and this is a more severe stage of the disease. And then occasionally, some dogs present other signs. Usually, these four related to severe immune dysfunction. They present ocular lesions like uveitis or panophthalmitis or glaucoma, or they present lameness due to arthritis and myositis or epistaxis. So some dogs in the advanced phase start to show more systemic signs. Initially, your patient can present with something like this. Simply a dog that is not itchy, is losing a little bit of weight, and present areas of alopecia and scaling on the face, on the nose, and on the ear tips. This is a more advanced case. This is usually, as you see, it's written in Spanish. This is a case from Barcelona. So you see that the dog here is developing this alopecia around the eyes, symmetric alopecia on the legs, with some scaling, some erythema. You see around the eyes some mild, and this is the ear. So you see this exfoliation of the epidermis is very typical of leishmaniasis. The dog is not itchy, it's not scratching, simply it's developing progressively hypotrichosis, alopecia, and scaling. This is the same dog. You see how it's losing hair, and you see the severe scaling or alopecia on the dorsum, or this area. When you look closer, it's like this. This is a most advanced case. This poor dog has been developing this alopecia all over the trunk, on the face, and a lot of scaling. And this is a more advanced given case of alopecia with exfoliation. The same dog with the very severe lesions on the face. 80%, 70 to 80% of the dogs present with this type of skin lesions, alopecia and desquamation. The rest, 20%, present other type of skin lesions. For instance, in German Shepherds, you see very frequently this type of erosive and ulcerative lesions, especially on the legs, on the face. See this very typical of leishmaniasis. They present these ulcers on the distal legs, sometimes of the face. And here you will see the same on this poor Jack Russell Terrier. Sometimes you see that on the face too. You see how probably these ulcers are related to vasculitis, to inflammation of the blood vessels, and you see that they follow the tracks of probably blood vessels. And this is the lesions on the leg. There is, in many cases, exaggerated growth of the nails, what we call onychogryphosis. So these are growing a lot, and in some cases, onychodystrophy. You see here the inflammation. You see that there is the alopecia and the scaling also, but with some ulcers. And here you see that this necrosis and ulcers of the distal part of the pinna. This is also very typical of leishmaniasis. You see the necrosis of the pinna So in fact, the disease is causing severe vasculitis and necrosis as a consequence of that. Here you see the same. A very small percentage of dogs present more than alopecia and exfoliation, this skin nodule. It was the case of this boxer with 2 big nodules on each ear, you will see. And sometimes the nodules like this with cross on top are located on the legs, maybe on the abdomen. So these are less common manifestation of the leishmaniasis. If you do a blood work and try to start doing some clinical pathology on these patients, there are a few changes in the blood work that can give you some information. Most of them, I would say around 80% of them present changes in serum proteins. So most of them present hyperproteinemia, 8, 9, 10 in proteins, that is connected to hyperglobulinemia. They have hypergammaglobulinemia, very prominent with a polyclonal pattern. And then the other changes are very unspecific. So some of them present azotemia, some of them present increases in liver enzymes. So about 70%, 2 out of 3%, some degree of proteinuria, because in leishmaniasis there is damage of the glomeruli and they start to leak protein. So there are some changes in the urinalysis. So how you can confirm a case of leishmaniasis? Imagine that you have a patient that has clinical signs or clinical pathologic abnormalities that are suggestive of leishmaniasis. Imagine that you have one dog that has been visiting Italy or Greece recently, and after a few weeks started to develop some alopecia and scaling. The dog is more or less sick, asthenic, and you do a blood work and you see mild anemia, you see elevated gamma globulins, and you say, oh my gosh, this could be leishmaniasis because it's not itchy, it's not responding to steroids or Apoquel. So what if this is a case of leishmaniasis? The easiest way to start the diagnosis is doing a quantitative serology. Don't do a fast test, a quick positive, negative, qualitative serology test. Do a good serology. Take a blood sample, send to a good lab, and do a good serology. This is the best test that you can do. There are other possibilities. You can do bone marrow aspirates, but begin with simply a serology. This is very sensitive. If it's high, probably you have a case of leishmaniasis. So 98% of sensitivity is the best way in general to start this. And it's negative, you can rule out leishmaniasis. There are very, very, very few cases that after more than 1 month of infection with clinical signs remain seronegative. Okay? What about the treatment? What is the most adequate treatment when you confirm a diagnosis of leishmaniasis? There are many treatments, but if you need to keep one in mind, let's see. To say, this is the clinical presentation, this is my diagnosis, what is my treatment, this is the best option. The combination of meglumine and timoniate, glucantine, and allopurinol. This combination of 2 drugs has many advantages. So this drug, antimoniate, which the brand name is glucantime, and it's produced by Merial, now Boehringer Ingelheim. So this drug is a drug that kills the parasites quite fast. So in 1 week or 10 days, the number of parasites drops immediately, and the dog starts to improve very quickly. You can use this usually for 5 weeks because you need to inject the drug every day subcutaneously, so it's not a treatment that you can maintain lifelong. It's not very expensive, so it's affordable, but it's quite intense for the dog because you have to give an injection every day. This drug induces a fast remission, reduce the parasite load, and allow the immune system to control again the infection. And these are the drug, allopurinol, it's a parasitostatic drug. It doesn't kill very quickly the parasite. It needs weeks to act. But it's very good controlling the progression of the parasite. So with this one, you reduce the amount of parasite. With this one, you maintain the parasite load. And you give an opportunity to the immune system to control this. We are not going to cure the infection. We have to know that. So as in many infectious diseases, what we are doing simply is to reduce the infection to a very low number where the immune system will gain control of the infection again. But these dogs probably remain infected with a very small parasitic load under the control of the immune system. And this happens in many other conditions. Now that we have good sensitive techniques, we know that if we do a PCR of these dogs 2 years after the treatment, when the dog is healthy and just happy and taking just the allopurinol, you can find some parasites. So they remain infected. As many dogs living in the endemic area, they are infected, but with very low parasite numbers. Simply that the immune system is taking care. Maybe myself, I'm infected with leishmania, probably, and my immune system is controlling the infection. Even in Italy or in Spain, in humans, they have done PCR tests to detect the parasite in blood banks. So in banks to give blood to people that need that. And they detect the parasite there in small numbers. So probably people and animals living in endemic areas are infected, but the parasite is under the control of the immune system. So this is what we do with this treatment. We try to reduce the parasite load and give an opportunity to the immune system to control that. So also, combining two drugs will reduce the possibility of causing resistances, because there are some concerns about the use of antimoniates in canine leishmaniasis, because this drug is also used in people for treating leishmaniasis. So if we use only one drug, it's easier to create resistances. So we start from the beginning with two drugs to reduce the possibility of resistances. Also, remember that with this treatment, what you do is to give an opportunity to the immune system to control the disease. So these patients need to be in a good health. So they need to have very good food. There's even one food for patients with leishmaniasis, but if not, buy the premium food for these patients. Don't give bad food. They need to be under the control of other parasites. You have to check for other infections. So you have to give good support to these patients to avoid a relapse of the disease. You will see that patients with chronic leishmaniasis that are doing relatively well, when they have another condition, or parasites, or Ehrlichia, you have Ehrlichia here, infections? Yes. When they develop Ehrlichiosis or any other parasite, then the leishmania goes up again. Because the immune system cannot do so many things. It's overloaded again. If you look in the paper, you will see that there are different stages of canine leishmaniasis. Most dogs are detected in what we call stage 2 and 3. And these are the dogs that I showed you. There is a stage 1 that is very mild disease, where dogs have no clinical signs, or very mild clinical signs, that are treated almost only with allopurinol. In stage 2 and 3, these are the dogs with the scaling, nodules, ulcers. We use a combination of allopurinol and glucantine. And in stage 4 is when they develop renal disease, kidney disease. They need to be treated by an internist as a severe case of kidney failure. And then you have to follow. First, try to control the kidney failure, use in some cases, or in many cases where they have proteinuria, so drugs to reduce the blood pressure, inhibitors of the converting enzyme and so on. Like in the case of pemphigus, you have to remember to the owner, remind to the owners, that this will be a lifelong treatment, that the dog will remain infected forever, and then you will need to keep the dog under control forever. And usually, we start with a recheck after 1 month of the treatment when we finish the antimoniate, then after 2 months and 3 months, and then every 6 months. Every 6 months we see the patient and we do a recheck, and then we do a full physical exam, CBC chemistry, urine, serum protein electrophoresis, and serology to see that the patient is under control. So they can let's say, flare in any moment. So I will show you one case just to show you how we manage these patients with leishmaniasis. This is a 2-year-old German Prague living in Barcelona, vaccinated, treated for parasite, eating good food. But 2 months ago developed nodules on one pinna, was treated by a vet with iodine without any improvement. And then 1 month later, started to develop nodules on the other pinna, and apart from that, is quite healthy. No systemic clinical signs, moderate lymphadenopathy, and when I saw the dog, presented 7 nodules on the external surface of the left pinna, and 9 nodules on the right pinna, and 1 small nodule on the nose. The nodules are dermal epidermal, quite deep, and in most cases ulcerated, and non-painful, non-pruritic. This is our patient, and then we will go to look at the nodules here. You see 1, 2, 3, 4, 5, 6, 7 here. And this is the other ear. And these are the nodules on a closer view. They are dermal, epidermal nodules with an ulcerated surface. So, what is the diagnosis of this patient? Well, it's the same that every time that you approach one patient with nodules. So, it can be inflammatory, infectious, or non-infectious. We can consider under infectious nodules leishmaniasis, mycobacteriosis. It could be, but it's a very well-defined syndrome, the canine leproid granuloma, that we know is an infection with one type of mycobacteria transmitted by flies. Could be cryptococcosis. We have cryptococcus in Barcelona, or any other deep mycosis. And it could be also a non-infectious nodule like eosinophilic granuloma, also common in dogs, or more common sterile pyogranuloma syndrome. And it could be a more hyperplastic neoplastic nodule. A good possibility would be what we call cutaneous reactive histiocytosis, which is a benign proliferation of dendritic cells of the dermis. It could be an histiocytic sarcoma. It's really young for a malignant neoplasia, but it could be or a mast cell tumor or a lymphoma. So this was my list of differential diagnoses. What are we going to do? Well, the investigation of these nodules is the same in all cases. We begin with a fine needle aspirate, cytology, we need a CBC, and serum biochemistry, urinalysis. We need a serology for leishmania. These can be nodules caused by leishmania. And then we are going to do a biopsy, and from the biopsy, we'll do a histopath, a fungal culture, and a bacterial culture. Remember that in a case like this one, if you take a culture from this area, you are basically collecting a sample of the skin surface. And this can be simply contamination. So I'm not interested in knowing what is living here on the top of this ulcerated skin. I am interested in knowing what is going on deep in the dermis of this nodule. So what I do is I take a biopsy, I took the deepest part of the biopsy and sent this to the lab